everywhere, but I'll go ahead and start by way of my background. I went to LSU, got degrees in zoology and political science, basically pre-med, pre-law, and then went on to the University of Minnesota Medical School, where between years 2 and 3, I took a year off to become the Government Relations Fellow for the American Medical Association. And it was really there that I learned about the upcoming mandate for doctors to adopt electronic health records. So they were going to make doctors adopt these record systems. And unfortunately, when I went back to school for my year 3 and 4 clerkships, where you actually rotate through the community and do all the different specialties and all that, I found that it would take me an hour to document a 15-minute encounter. So I spent 15 minutes with the patient and an hour in front of the computer reliving the encounter. And I knew that wasn't going to work for me or any other doc, despite the fact that I ran my 8th grade library computer system, built websites through college. I love computers, and I did not love this. And so I knew as someone who loved computers didn't like it, then most folks weren't. So during that time, I also was on the comprehensive review of the USMLE, which is the medical licensing exam for the physicians. And I helped write the exam for 3 years, the first step of the three-step exam. It was subsequent to that I had an idea that there had to be a better way than spending an hour in front of a computer for 15 minutes with a patient. And so I went on to Yale to get a master's in public health and administration, where I spent about half my time at the Yale New Haven Hospital and about half my time at the School of Management. And so if that kind of gives you some context for my approach to technology, this is sort of informed from a sort of broad global perspective what our approach is, but we're going to sort of back up from what we're doing and sort of start at the ground level and build up to it. And so I'm here to talk about tonight essentially the Internet of Things and how these devices connect and what that might mean for the future, and then how that applies to healthcare. And so what is the Internet of Things as it's come to be known? It's basically connected devices of many, many types. It could be a connected outlet in your home that you can turn your lights on or off. It could be a camera in your house. It could be any of these devices, a door lock, you name it, or your phone, or a sensor on your armband to monitor your health. It's all of these devices that are connected and sort of come to be known as the Internet of Things. What is the purpose of this? Well, part of it is quantify itself. How much energy are we using? Both electricity as well as calories burning during the day walking and these kinds of things. We're trying to reduce waste. When I'm not home and I forget to turn the air conditioner off, wouldn't it be nice to be able to just turn the air conditioner down from my phone, or better yet, have my phone detect that I left my house? Because I have what's called a geofence, right? I can sort of set my location on my device, and when I leave my house, my air conditioner automatically sets itself. And then when I'm on my way back, when I get within a couple of miles, cranks on the air conditioner for me so it's cool when I get home. So all of these things are happening, and that's called the Internet of Things. The risk and challenges primarily are around privacy and security, right? So if you can turn your lights on and off and lock and unlock your door, then someone else might be able to as well. And so there are some risks and challenges with this, and what's interesting is a lot of the what you might consider the Internet of Things was originally created insecure. So like the red lights, you can get the infrared signal, go through the red light for the emergency vehicles, and use the same infrared and control the red lights. Or if you've ever seen the road signs when they've been hacked, to say something funny, instead of road work ahead, it's got like, some mama joke or some kind of
double tap
something.
Just to be sure.
Yeah, right. So that's so a lot of these things are insecure. So finally, we're getting to a point where privacy and security have become a foremost consideration when we create these devices. And so how does this happen in the home, this Internet of Things? And so I talked a little bit about the camera up in the upper left. You'll see it's something you can mount anywhere. I have one in my own house to help watch the kids when we're in another part of the house. Another example would be called Smart Things. And basically what it is a little hub you get, and you can connect all kind of devices. This is one of the devices. It's a plug, so I can control lamps or whatnot, lock doors. One of the things that I like, and I get these to experiment for their applications in healthcare, is a motion sensor. And so again, here with this automation, you can put the motion sensor in the living room or in the kitchen or whatever, and monitor someone else without them feeling like their privacy is being violated. So, you know, if you have the camera, it feels a little weird. I mean, sitting in my living room, it feels a little weird, I gotta be honest. But I like the motion sensor because then you can see that there's movement, which is really what you're concerned about. You know, if it's an elderly person or if it's someone with some disabilities that maybe hasn't moved around in a day or two, you might want to know that. And so there are some balances to be struck here with the motion sensor versus the camera. The thermostat, as I mentioned, one of these as well, is very nice. It's a Nest. Google bought them, I believe, recently, but it's a digital thermostat you can control from your phone and everything else. And then what we're getting to over time, and they're just starting to hit the market, I think, in a significant way, is the connected appliances. So we've all heard about the smart refrigerator for years, where it's got the RFID tag or some sort of radio tag. You put it in the refrigerator, and it knows, you know, how much milk you use and when you need to, you know, order your groceries and all these different things. Stoves and the like, where you can, you know, check the how much time is left on the microwave from the stove interface, and all these different things. So basically, this tied together is what has become known as the Internet of Things. I just wanted to give you a few examples of what that means. And so then we take it down one level to smartphones. And so what's great about smartphones is they're always with you. They're essentially computers in your pocket. I remember about 5 years ago, I got a phone that had the same specs as my top-of-the-line desktop that I got as a senior in high school. That was a tower desktop that, you know, couldn't fit in the front seat of my car, and now it fits in the palm of my hand. So it's pretty amazing how far they've come. As we talked about before, the cloud, well, that's what smartphones sort of serve, and that's what they use. So a lot of the processing doesn't happen on the actual device, it happens in the cloud, which is essentially just servers somewhere else, right? As you guys well know, just want to make sure everybody's on the same page. But it's always on, right? It's data stored somewhere else, and you know, as I mentioned earlier, some of the good things about that is the fact that you can use these devices and automate things. So events and actions can occur in the background, as I mentioned earlier with the thermostat and you coming and going from your house. And so what is also great about these smartphones is that they have all these sensors. And so the sensors can give you this rich information that I alluded to on the last slide. And so you can see they have an accelerometer, so how fast is it moving, a gyroscope, what orientation is it in, a magnetometer, you know, is there electricity around magnetic fields, a barometer, so atmospheric pressure, underwater pressure, proximity sensors, is something close to the phone, light sensors, is the phone in your pocket, is it in the light, of course the touch screen, so that's the electricity in your finger, the capacitive touch, GPS, so your location in the world, Wi-Fi, which not only connects you to the internet, but also can help serve as a location. You might have seen on your phone, it says, you know, turn on your Wi-Fi for improved location accuracy and these types of things. The Bluetooth, which is increasingly popular with various types of devices. The cell itself, the near field communication, so that's the digital wallet. And so anyways, and the cameras, the front and back cameras, and the various things you can do with the cameras themselves, like a pulse oximeter. You know, you can download this app, it turns on your camera light, you put your finger up to the camera, and you can not oximeter rather, but your heart rate, your pulse. Just with the back of the camera, it'll detect that for you. So there's some really interesting things that you can do with all of these sensors, like walking, how many steps you take, and all these different things. But you really have a full suite of sensors right on your mobile device these days. What does that provide for? Well, as we talked a little bit about before, this cloud and automation. So it can tell you what the best route is to get home. It can tell you the best restaurants to eat at. It can tell you your air conditioner, when to turn on, when to turn off, your lights, your doors. I mean, all of this stuff can be automated, and it's really a new and fascinating world we're living in. I think, you know, much like some personal editorial, I think much like the revolution of the car and the radio, the cell phone far exceeds those, and ultimately this technology is going to create a different world. You know, much as it was 100 years ago, 100 years from now, we'll look back and see this as a time of major transition. And so, I'm going to lose my end. Sorry. And so as we drill down sort of one step further, specifically to healthcare, we want to look at the problem. So nearly 1 in 2 Americans, adults live with at least one chronic illness, so chronic illness is an issue. We spend about $8,600 per person on healthcare, 30% higher than the closest industrialized nation. Life expectancy at birth is estimated at 78.62 years, ranking 51st globally. And there are between 210 and 410,000 deaths due to medical errors per year, most of which are preventable, making medical errors the third leading cause of death in the United States after heart disease and cancer. So we got real problems in healthcare. And so what can we do about that? Well, we want to train people better, we want to create better systems, but technology can help make those systems better, help to complement those systems and work with those systems. What are some of the things that sort of contrast with how we started to do things initially with how we're going to do things in the future? And the one contrast is passive data collection. And so we talked about these sensors, we talked about all these various devices. Now, the way we used to collect data, and in many cases we do now, is I'm going to spend the 15 minutes with the patient and the hour documenting the encounter because I'm going to do it manually. I'm going to type it in, every word, every character, every line. But in the future, we're going to do it in the background. So when I'm done seeing the patient, first of all, I get to focus completely on the patient. So I don't have my back to the patient. I don't have a computer as a physical and emotional barrier between me and the patient. I can talk eyeball to eyeball. So it's really using technology to take me to a time past when the doctor or nurse could focus 100% on the patient like they should and not on the bill. And so that's what makes it exciting about collecting this data in the background in a natural way. We'll go through that. Structured data. Structured data just means data that has structure that's reproducible, that is discrete and can be used for analytics. So for instance, in our system, you can't really misspell any words. Everything is autocomplete. That's kind of what structured data is all about. So you can compare, pain levels of a patient who came in complaining of one thing or another, and how they line up. Machine learning. Now, what's interesting, and we're sort of, if you notice, this is the sort of flow, right? So that you got to collect the data, and then it's got to be of a certain data type. And then the third point, machine learning, is now you have that data, it's structured, you can use it to understand complex trends in the data. And convert that data, that raw data, to information that's actionable, that we can actually do something with. And therein lies the value of predictive modeling. As the name suggests, it is intended to use that information to discern patterns and proactively anticipate illness and minimize suffering. And so what that does is, let's say a diabetic is having trouble managing their blood sugars. Well, let's say there's 500 patients in their city that have similar trends, that have similar diagnoses, similar problems as they do, or on similar medications. And they can see these trends where it might spike and then drop and spike again, and if you get the double spike, then that means you're going to have a diabetes exacerbation within the next day. It is like a 70% chance, right? Well, if we can prevent you from having that diabetes exacerbation because the computer sees that double spike without having to have someone look at your reports every day, the computer sees it and then alerts your nurse or alerts your doctor or alerts you, hey, we saw something that looks a little troubling, let's, and offer steps to remedy that before you end up in the hospital. And so this really can have a significant effect. And so that's what we're building to. I don't know why I keep that up. There we go. So some of the solutions, we have to have security, privacy, the encryption, I'll come back to it. If you would write down the question, I'll come back to it right when I finish this. Really not much longer, so I wanted to leave a lot of time for questions because that's what's most fun for me anyways. Security, and that's the encryption, you guys are familiar with that. One of the things that is of note is we have to teach ourselves and each other how to avoid things like brute force attacks is a little bit harder to avoid, but things like phishing and spear phishing, where, as I heard one report with the iCloud incident, one of the celebrities was called by someone imitating an Apple representative and said, hey, I'm calling you from Apple, you just had service the other day, what was your password so we can check the status of your whatever? And that's how they got access to that. So we have to be very careful about who we give what information to. Availability, so it doesn't do us any good if we don't have that information. If it's not available to us as patients, then we can't do anything with it. Accessibility, so it's not only got to be available to you as a patient in your own record, but it's also got to be accessible. You need to be able to access it over the internet or from your mobile device or whatever means you have. And then accuracy. It's got to be accurate. If it's not accurate, then again, it does us no good. And so these are some of the solutions we're having to deal with now in digital health. And digital health, of course, is just a moniker for health that uses computers or technology of some sort. And so what are the possibilities about how we might deploy these technologies? Well, they range widely. Phone-based mobile monitoring, we'll go through each of these and give examples. So phone-based mobile monitoring, home-based and remote monitoring, wearables, actually devices that you can wear and sort of live with. And then telehealth, so remote health, where you can have these sensors at your house, access your doctor through a computer, and they can see all of the information, the vitals or labs or whatnot, your physician or provider may be concerned with, and provide that without actually a face-to-face visit. And then some of the new technologies that are a little bit like Star Trek and beyond, very interesting. So digital health, phone-based mobile monitoring, up in the upper left is actually an EKG that you can do on the phone. You plug it into the phone, you put a couple of leads on, and they can do an EKG right there on the phone. There's actually a few news reports of that saving people's lives. This other one down here in the lower right is a pulse oximeter. So you put the little device on your finger, plug it into the phone, and they can tell you your pulse, your oxygen levels, and various vital signs. And then the one in the upper right is an asthma inhaler that's got a little GPS and Bluetooth device connected to it. So it knows how many puffs you're taking and where you're taking them. And so this is part of that cloud, part of that data, part of that predictive modeling and some of this analytics is it knows what areas most people are puffing in. And so those will show up red on a map, and if you go into that area, it will alert you, hey, this is a high-risk area. Other asthma folks have had exacerbations in this area. You may want to go somewhere else. So these things can be very helpful, especially as we integrate them into our lifestyles. Remote monitoring. This is one of our partners as well. It's very interesting. They use a little box just like this. Qualcomm makes it. Qualcomm you may recognize from some of the cell phone chips and things like that. Maybe some of your first phones were Qualcomm. But what they do is this is a connected hub that can connect all these devices and then send that data back over the air. So the user doesn't need a computer. They don't need internet. They don't need anything. All they need is their devices. That connects with this. You plug it right into the wall, and that will send it back over the air to your doctor's office or your provider. So that helps with people who don't use technology very well or may not be able to afford the technology. There are solutions that help with that. And then it can monitor things like medications that you see with the Clever Cap, how many times you took it on and off. The wearables. Now this is another area where you get the fitness band. You can put it on. It can measure heart rate, blood pressure, temp, various things, calories, how many steps, all kind of things these things can do. Fitbit is another example where you can kind of clip it onto your pocket or onto your waist. And so there's a whole segment of the market that's actually going after those to make it easy. Again, we're going back to this theme of passive data collection. You're not having to do anything extra. You clip it on and you go, and it does everything else for you. So that's that passive nature where you don't have to stop what you're doing and to interact with the devices. Then of course telehealth. You can see it here. That's the device where it sends the data back over the air. You have your little devices at home, and the doc and you are able to discuss what they're finding over long distance. So rural these types of setting. And so some of the new technologies, of course, as a self-espoused technologist, this is what's most exciting to me at this point. We have in the upper left what's called 23andMe. What they'll do is they'll take your DNA, they'll analyze, you do a little swab at home, they send you a little thing, you swab your mouth, put it back in the jar and send it back to them, and they'll analyze your DNA and tell you what sensitivities you might have, what medications might build up in your body, what medications might be more effective than others, and what risks you have moving forward, heart disease and stroke and cancer and these types of things. So it's very interesting because when you can couple that data with your clinical data, now we're getting somewhere. And they call that personalized medicine. Yeah, right. Well, there's laws that help with that. But I'd love to answer questions if you guys have questions about that. The other one that just came out today in the upper right is a face video scan that detects heart disease. So all they got to do is scan your face, and they can tell whether or not you have heart disease. Pretty remarkable stuff. This one in the lower left is a lab on a chip. And so all you have to do is take one drop of blood, you put it on the chip, and then it will analyze all of your chemistry and your blood values right there on the chip and send that back to your doctor's office. You never have to go anywhere. They're doing one, I saw an article the other day, where they don't even have to use blood. They just put a sensor up to your skin and can measure many of the same chemicals. It's pretty impressive. And then, right, I mean, it's pretty powerful stuff. And then finally, as you can see here, the Qualcomm Health is sponsoring what they're calling the Tricorder Prize. Now, in this group there may be some, but Star Trek is where that comes from if you're unfamiliar with the tricorder, and basically it's a device that will diagnose you by itself. And so they have about 10 companies that have been accepted to compete to produce a product that can do that, likely using a combination of many of the things we've talked about today, whether it's the picture of the face versus the lab on a chip versus some of these other things, that the DNA and a few other things. So it's very exciting. And so just to kind of wrap up that portion with by the numbers, so remote patient monitoring has the fastest growing revenue of any device sector and are predicted to save the world's healthcare systems up to $36 billion by 2018. Between 29 and 52 million unpaid caregivers provide care to someone age 18 years or older who is ill and has a disability. And 9 in 10 caregivers own a cell phone, and 1/3 have used it to gather health information. So these phones, these computers in your pocket are very powerful things for caregivers alike. 8 in 10 caregivers have access to the internet. Of these, 88% look online for their health information. The vast majority of patients, 90%, want to self-manage their health care by leveraging technology, such as access, as we mentioned earlier, to health medical information, refilling prescriptions, and booking appointments. And then finally, in 2011, annual expenditures for home health care are expected to be $86.8 billion by this year. So it's a growing market. It's something that's got to happen. We just don't have enough resources in the pipeline to be able to meet the demand. And so one of the things that I thought I would mention, because this group particularly might find it of interest, is I don't know if you can recognize some of these icons, but for instance, if it's a location, then it's got the little green dot. If it's the little triangle, then that's Google Drive. If it's the little camera face, then that's a picture. That's Instagram, social network. If it's ESPN, you see here in about the 5th line, then it'll send a notification. What that is it's a website called IFT. It's if this, then that. And it's very cool, because what can you do with it? Well, you can tie together these various services and make things happen. That's this automation that I'm talking about when we get to this idea of tying it all together. So if this happens, then that happens. And so if I'm in a particular location, then save it to Google Drive. Or if I post a picture to Instagram, also save it to Google Drive. If ESPN has a particular team that I'm following, has an alert, then notify me on my phone. So you can tie together all of these services and make things happen that are unrelated services based on a conditional statement of if this, then that. So it's a pretty powerful service. I know a lot of hackers and tech gurus love that service. And so, again, in this notion of tying it all together, as we sort of round out the presentation here, I want to tell you a little bit about how we're doing that at our company. Again, I'm not trying to sell anything. Just want to share with you a little bit about what we're doing. So this is kind of how we feel like the clinical encounter is gone. You know, docs don't even look at patients anymore. It's all about the claim. It's all about the bill. And so what we found in studies is 43% of the time is the amount of time docs are spending doing data entry, as I mentioned, that hour for the 15-minute encounter. 28% of the time they're spending with patients. That's a problem. They're doing 4,000 mouse clicks per shift. And to give you an idea, it's a low of 6 clicks for an aspirin and 227 for abdominal pain. So it's a lot of clicking and a lot of doing, wasting time doing things they weren't trained to do when they could be spending time doing things they were trained to do, and that's taking care of people. And so our job when we set out was to do away with that hour documentation that we talked about, to take the 300-click encounter and make it the 10-click encounter. And so we've done that. We've put together a lot of the principles that we discussed here today. This passive, automated clinical documentation, that's what we do, that adds on to a legacy EHR system, so it'll add on to an older system, much like some of these services talking to each other. It complements the provider workflow. So again, this is that passive stuff in the background, allows you to be person to person and eyeball to eyeball with the patient. It's cloud-based, interoperable, and standards-driven. So that standards-driven allows us to interact with other systems in a predictable way. And then it uses structured, scalable data for deep analytics. You know, we talked about that structured data earlier. That's that data that you're able to do analytics on. So think about if someone says headache, they type in headache, but they put a K instead of an H at the end of headache. Or they put headache and forgot the E, so now it's headache. We can't have that, because you can't do anything with that. That is called unstructured data. Structured data is when you type in HEAD, the options come down for headache, you choose headache, and then go on. It's always spelled correctly every time. Matter of fact, you can't put in HADACHE. It just won't take it. You have to choose a proper description. So that allows us to do all that analytics and that predictive modeling and some of the exciting things we talked about earlier. So what is our innovation? What are we bringing to the table that is new and interesting? We're automating clinical documentation. So what does that mean? Well, we start with a fully aware clinic. And so each doc has a name badge, much like their current name badge, except it's got an RFID tag built into it. And so for those who are unfamiliar, RFID, radio frequency identification device, there are these little tags that come in every form, and you know, you can get strips, you can get plates, you can get these little tags like this. They come in wristbands. You know, I went to Disney World for the first time recently, and they were using something like an RFID tag. It's a little band, and it's your credit card, it's your park passes, it's your everything. You just scan the band and go, and it pulls up your picture, and they say, "Thank you, Dr. Ragusa." And I mean, it's kind of creepy, but it's pretty cool. And so the way we employ that is when the patient walks in the clinic, they get a little tag like this that has their number on it. Well, they then are able to see what room they go to and then go to their room. And it enables real-time events in the background so that when the provider walks into the exam room with the patient, now we know they're in the same room together, right? So it triggers our mobile app to begin listening to that conversation. It's streaming. It's not recording. We don't want that liability. It's streaming. So what happens is, in the background, the doctor walks in, the device begins collecting that audio through a little headset, much like this one here. It goes around the doc's neck. Nice thing about it is, it's got earbuds, and so you can have a two-way, you know, so if they're answering a phone or they want to communicate, you know, they want to do voice to text, whatever, then they can do that with the headset there. But in the meantime, it sits very comfortably on the neck in the background, and you have your natural conversation. And what happens is that's converted to text. And then we extract the relevant text out of that transcript and then destroy the audio and the full text record. So the only things that are saved are medically relevant things. And so then we combine that with your existing patient record and propose to the doctor the list of most likely diagnoses. So we don't eliminate the doctor, we help the doctor. We can't eliminate the doctor because that person has to make the final decision. So we just try to help them as much as we can. And so we give them a list of most likely diagnoses from which they can choose the most likely diagnosis. And so what is the significance of that? When they choose the diagnosis, and then they choose from a very specific list of plans, all documentation is complete, the orders are sent. So that's your prescriptions, your labs, your radiology, your these types of things. The claim is onto the paper, and the patient summary is in the record. So in under 1 minute, what used to be on the best day, an 8 to 12 minute process. For me, it was an hour, but you know, let's give them some slack here. 8 to 12 minutes is now under 1 minute, and as few as 10 clicks, and all of the process that normally would take days and weeks is done by the time the patient leaves the clinic. Pretty powerful stuff. And so as we tie it all together, so really what happened for us was we realized we wanted to do this add-on documentation solution, but it was going to be very difficult to get one of these major vendors to allow us to come in and like kind of make their product look bad, right? I mean, they're not, you know, it's like the new bells and whistles, but it's not their bells and whistles. They don't want to let it sort of onto their platform, right? So we ended up being in a position where we kind of had to create our own platform. We were going to go try to program against Vista, which is the VA's medical record system. It's great. Problem is, it's built on technology that's about 70 years old. Some of you tech historians that might be interested in Massachusetts Unified Messaging Protocol. It's basically called MUMPS. It's what all of the major vendors are on right now. It's kind of interesting how all that's worked out. But suffice it to say, we ended up having to build it ourselves, and because we were building the documentation component, well, what do you need for documentation? You need the full medical record, right? Because it's going to pull in past medical history and social history and family history and all of these different things. So we had to build that. Well, in the course of building that, we figured, well, if a person is a person, then why do we need 10, 15, 12, 25, in some cases, 25 different systems that are all using the same data? It's the same person. And it's just shuffled from system to system, sometimes inaccurately, as you may have found in your own experience. And so why is it like that? Why even bother? And so what we've done is we've created this complete platform with a single user interface. So there's no more practice management system as a standalone system where you manage your hour, your scheduling, and no more revenue cycle management system where you manage your claims and getting paid, and another system that's a scheduling system where you manage your patient schedules. And I mean, literally, at our beta site, right, our second site going live, there's 18 different systems. We're replacing all 18 of those and adding about 6 more, but simplifying all of it by having one user interface. So the doc and the staff doesn't have to log into 10 different systems. You as a patient would have to log into 3 different systems to access all of your information in the range of sort of silos and places it's in. We thought that was crazy. And so what we've done is we've put together, and I'll roll it back, the electronic health record with all of the imaging, the e-prescribing, e-labs, e-radiology, and the surgical documentation. The full messaging platform, so you don't have to have a different phone and fax and email and all this. It's all in one. So phone, fax, text, voice, and video, all in one system. The patient portal with appointment scheduling, you can view all of your information. Matter of fact, most systems now, it's duplicated out of the medical record and put in a patient portal, like that's separate, and like you don't deserve access to all of your information. Our system is one record system. You see the same interface as the doctor, as the nurse. It's your record, it's your system, it's your data. And so we feel like that's important. And so you see the same information as the doctor sees. The nice thing is we put little information links from reliable sources. So if you want to know more, you don't have to go search some blog and hear some horror story about the worst case scenario. You can find very patient-friendly information right in context. The vendor contracts managers is automated clinical documentation. I'll walk you through the process. Patient registration with the vital station where you walk up with your badge, scan it on the little device, and then it'll come up on the computer. You verify you're you weigh yourself, you do your height, you put the thing in the blood pressure machine, and then all of your information is just there. It's very, very easy and very seamless. Home and mobile monitoring, we mentioned that with the telehealth earlier. The RFID and location awareness, as well as asset inventory and asset tracking. So we're not just tracking people, we're also tracking things. The patient account for clinical data reporting, so all of your financial stuff is there in one spot with the clinical data reporting, and then the health information exchange on the back end. And so all in one system. It's taken us about 4 years to build, about $3.5 million. We have about 15 physician investors. We're still raising money. Anyone's looking to invest, but it's been quite a journey. We are housed out of the Bio Innovation Center, and we're a real purpose-driven organization. That's part of the reason we're here tonight, is because we feel like it's important to get the community involved and share our vision and hear feedback and questions and concerns, and just help to be part of the dialogue. So. That's really all I have as far as a formal presentation, but I'd love to take questions or anything like that. Yes, sir, in the back. He wanted to ask it earlier, so I was going to ask. Yes, sir, in the back. Oh, wait, sorry.
There's a local company called Renaissance RX that's doing the DNA personalized medicine, but it was not supposed to be done. And also, it said also with the market structure data. When you say that, what I'm thinking of is like now, you took something like Hobby Watson, and what it's doing, well, relatively unstructured, with scientific journals and what have you. Imagine that to what's happening to what the patient is doing. You have unstructured data, and patient history, which is also somewhat unstructured. and it's matching those together. So how does, who are you cooperating with to build diagnostics?
So the new paradigm in business, at least as I see it, is partnerships, right? So you don't have enough time or energy or resources to start a company and try to do it all yourself. So we have about 15 partners. We're constantly adding partners. One of those is Isabel. So they're the Watson competitor. You can take a few terms and it'll give you the most likely diagnosis. So we don't do that ourselves, but it's baked right within our system. To the point about Watson, we know that, and we saw that, and obviously I've been studying that for years. The interesting part about it is it tries to make sense of unstructured data. And Watson has proven that that's nearly impossible. I mean, they've basically given up on healthcare overall and decided to focus on very specific and narrow targets, like a particular medication in cancer research or a particular, something of that nature, because as you guys well know, if you put crap data in, you're going to get crap information out. It's just how it works. And so that was really part of the driving force about why we did it the way we did, where we structure data. Now we give the flexibility to the clinic or the organization or your doctor to be able to go in and change a dictionary. So all of our system is dictionarized, right? So if a symptom that you want to appear as a provider doesn't appear when you try to put that in or you try to speak it in, then you can modify the dictionary to make it appear so that it is there. So it tries to strike that balance between being restrictive and only allowing certain things in input, but keeping that clean in the structured data form, so you're able to go to the dictionary and change that so that it will appear. But it will have to appear that way, or else. So if you misspell something in the dictionary, there's not really much we can do about that. But we can detect it a lot easier. And so, we don't have to use very powerful machines like Watson to figure out if H-A-D-A-C-H-E and H-E-A-D-A-C-H-E and H-E-A-D-A-K-E and, all these different things mean headache, right? We don't have to try to figure that out statistically, and there's no guesswork. So it's an important point, but I guess my bottom line on it is I hope that we're moving to a world where all of the data is structured, because we can't really do anything. I mean, as Watson has proven, that it can beat the Jeopardy guys, but it can't figure out medical notes. So yes, sir.
I'm assuming you say Watson, you're talking about the IBM supercomputer?
Absolutely, yes, sir.
Okay. You said you headquartered out of the Bio-Innovation. Is that on Canal Street?
Yes, sir. Yes, sir.
Technology Center out of the
No, sir, it's on Canal Street.
On Canal Street. Number 3, the RFID, I mean, is that actually going to monitor you when you're using the bathroom too?
We don't have antennas in the bathroom. So just to kind of give you a sense, as you guys may be interested, the way RFID works is you have a reader, which is much like a router. It's sort of the same concept. You have this is connected to the internet, through a switch, a network switch or whatever. Through here, it's power over Ethernet, so you don't need to plug in the wall. You can use it over the Ethernet. And then from the back of here, it connects here, wherever this antenna. So you have a reader and an antenna, wherever the antenna is. In our beta site, they're all behind the walls. They're all, so you can't see them. So they can be pretty slick in that way. There are limitations. Water is a limitation. So you can't put the tag too close to your body because the radio waves are sort of absorbed by water. And the other part is it only detects where it sees you. So it's a last seen technology, which means that it only knows you as accurately as the last time you were in a place where there was an antenna. So not in the bathroom, unless you want to know if people are in the bathroom, and maybe there's some value to that. I mean, if you're in a hospital and somebody spends 35 minutes in the bathroom, then maybe somebody needs to go check on the person in the bathroom. So there are contexts where, even though it seems a little bit bizarre, it actually could be useful and help save people's lives. Yes, sir.
We all know what the 3 major credit bureaus are.
Sure.
Collection of data. There is such a thing called Medical Information Bureau, the MIB. Okay. Is this MIB on steroids?
Well, I mean, it could be. The one thing, so you have to have very strong passwords. So our system doesn't allow less than 8 characters with punctuation marks, with all these other things. The other part is we use 256-bit encryption. The other part is we give you access to your own audit log. So if anybody has viewed or accessed or changed or anything your record, then you can see that. And you can set it up to alert you anytime that happens. And so, you know, I was a patient long before I was a doctor. And so I carry that with me. And I'm a very patient-centered physician. I would like to think, you know, my patients in medical school remember my name. They didn't remember a lot of medical students' names, and I'd like to think it was because they could tell I cared a lot about them. And I spent time with them, and, you know, I love patients. That's why I wanted to be a doctor since I was 3 years old. I never wanted to be anything else. My mom said I wanted to be a police officer for 3 weeks, and then I wanted to be a doctor, and that was all I've ever wanted to be. And I still want to be a doctor. I still want to go back to, not medical school, I want to go to residency and continue my craft and my vocation, but just couldn't do it with the current systems. And so while in some sense it could be, and we're always vulnerable to those types of security things and all that, I can tell you as a patient first that we'll be doing everything we can to make sure that doesn't happen.
Thank you.
Yes, sir.
You remember, you will enough to remember, in the early 70s, there was a record called Sager and Evans, called in the year 2525. One of the verses in it was, your legs got nothing to do, some machines doing that for you.
No kidding.
That, you gotta listen to the words of the whole thing, but that's one of the things we sing out. Your legs got nothing to do, some machines doing that for you.
Oh, that's fascinating. Well, we're trying not to replace your legs. We're trying to help you walk better and get stronger.
There'll be another company replacing different pieces, including eyes.
Yes, sir.
Monday night on stewardship.
John Stewart?
Yeah, he's had a fellow at MIT who just published a book called Internet of Things.
That's right.
And he has some examples of things that they're working on very similar to what you have.
Wasn't that very cool? I saw that. I thought that was interesting. And so if there's one more question, I'll answer that. And then I'd like to show you all this brief video that kind of summarizes what we're talking about here. Yes, sir. Oh, is that? I'm sorry, I didn't. Yes, sir. Yes, sir.
Would your data work as their data?
It would, to the degree their data is structured. That's right. Now, the interesting part about that is, while their data might not have started structured, that's what you really need, that standards thing, right? You really need, I mean, PDF, right? The reason that we send PDFs is because everybody's got a reader for a PDF, right? So then it's a standard, right? You can send it out, everybody can understand it, everybody can save as a PDF and all that. So it needs to be structured. What's nice is, as part of this mandate to adopt medical records that the government has charged physicians with doing, is they're increasingly mandating the structuring of that data. So for instance, family history. Used to be however you wanted to record it as a vendor, you could record it. Mom, dad, aunt, uncle, whatever, their problem, when it started, whatever. Now there's actually a framework that says, all right, everybody's got to record family history in this way. And so now what that does is means that we can not only exchange your diagnoses, which has been structured for a while in what's called the ICD code, right, the International Classification of Diseases, that house your diagnosis. Now we can move to your family history. And now we can move to some of these other things that heretofore have not been structured and therefore have not been easily exchangeable. Now they'll be increasingly easily exchangeable. Not easily, but increasingly easily.
One more question.
Please, yes, sir.
I find this all fascinating. I feel is technology. So, what, like, isn't that a good check and balance on it? Because, you not having perfect records, you train that and this diagnosis one time. Like, in other words, they're like, you check and make sure you're doing it wrong.
It's the doctor. And that's why we built it that way. We didn't make the diagnosis, we just teed up the 30 most likely. We said, look, if all the things we know, we can get it down to 30. But then when you, the doctor, or you, the nurse, or whoever's making that decision, has to then choose from that list. And so,
hey, what's that? And B, B, when you go talk to them, C, how wise it even is my visit. So in other words, whose job is it to make sure that your analyst is comfortable? Like, who introduces your analyst to me, I guess? Would that be the doctor's job? Or how's that?
right. Well, the idea is that it's happening in the background, so theoretically you wouldn't even know it's there per se. It's not. It's meant to be non-intrusive, right? So the doctor shouldn't be having it out and pulling it in. Matter of fact, that's why when you walk in the door, when the doctor walks in the door, it comes on in the background. So they don't have to be fumbling with their device as they're walking with you, trying to shake your hand and not drop their device and all these things. So that was part of it. Right from the outset, it's eyeball to eyeball. As far as the concern there, we do destroy the audio and the full text record as soon as it's created. Now, you guys, I'm not sure how familiar you are with things like man-in-the-middle attacks or some sort of hacking where there's somebody sort of standing between the endpoints of the data, between the beginning and the end, who would get in between that. And that's something that we have our own processes and algorithms for making sure that doesn't happen. But as you mentioned, it's imperfect. The question I have is, why are we so much less comfortable with encrypted data, which is what a 256-bit encrypted military-grade encryption? Why are we so much less comfortable with that than we are with fax machines and text messages and email, none of which are truly encrypted data? As a matter of fact, fax machines, which is modus operandi at every lab and radiology department and clinic you ever went to, that's like the gold standard, and it's like the least secure technology you can imagine.
That's right. That's exactly where it is.
This thing could destroy me and deceive me. I don't believe it can turn my mind too much. You can make me a zombie. So I guess it's pretty much like you would have to, I guess, psychological wise, you would have to kind of, I guess, we can use what I do is maybe like a focus, like pretty much how artificial products be. Like,
sure.
Like the device machine. It was scared of that. But if you market to me, introduce me to it, I'm more likely to accept it. I guess that's kind of my.
So one of the things we're doing to that is this whole patient-centered thing, right? So the messaging, and you'll be able to access all your data and all that, but how do we get you over that barrier? How do we get you comfortable with the idea that all this stuff is in the cloud, what is the trade-off? We have to, it's our job as a vendor and as medicine to make it clear what value this is providing to you. And so, for instance, we told you we didn't record the audio, but what if the patient, so in our model, we had thought about it initially, let's record the audio, right? It acts much like a police camera would. It records the patient, and it records the doc, and it protects the patient, and it protects the doc, right? And so that was the only part of our whole presentation that anybody ever sort of shuddered at or had any reservations about. I think why is because it was the doctor's side, right, where you don't have any control. It was the doctor's side that was doing it. But what if it was on the patient side? What if you walked in with your app and you knew you were checked in and it was anticipating you before you got there, right? That's what we're talking about with GPS. My system knows that I have an appointment in 10 minutes. Now it's going to wake up 10 minutes before my appointment and see where I am and ask my phone where I am every minute leading up to my appointment. When I get there, it's going to automatically check me in. It'll tell the front desk I'm there. I'll just grab a badge and put in the number, and there, so there's a process. But then, what happens when I get into the doctor's office or the exam room, and sometimes this news is bad. It can be very jarring, very stressful, and you may not remember anything. And so a lot of people nowadays will take very meticulous notes. That's one way. The other way is to bring in their own little personal recorder. And I'm thinking, well, if we have this digital system, we got about 80, 90% penetration of these smartphones, why don't we just make it to where the patient can initiate what parts of the conversation are recorded and what parts aren't. Now we're getting somewhere. Now, as a patient, if I want to, in my own accord, I can delete that. I can share it with my family members. I can share it with other folks. And so now, the point is, we have to make it valuable enough to the patient for them to be willing to make the trade-off. And that's where we stand, and I think we're on the right track, and we'd love to hear from folks like all of you guys to that end. So let me play this, and I'll be happy to take questions as long as y'all want, but I just wanted to show you a succinct kind of summary of one of the leaders in medicine and what they're talking about on a national news broadcast. And we can stop it before the 9 minutes. Maybe we'll let it run to like 5 minutes. But just so you get a sense of
science fiction. Dr. Nancy Snyder reports on how your smartphone may change medicine, including warning you of a heart attack. Welcome back. In our next story here tonight, we're about to hear one of the world's top physicians say the smartphone may change his profession and personal medical care in ways none of us saw coming. His story tonight from Dr. Nancy Snyder.
Why do we have people being treated like cattle herd? That's waste. And the billions of dollars that's being wasted each year for screening and the wrong drugs and the wrong everything. It's astounding. And we just can't go on like this. You know,
Dr. Eric Topol has long been one of the world's foremost cardiologists.
And great to see you.
He has now become the foremost expert in the exploding field of wireless medicine. And this explosion, he says, is about to make our healthcare better and cheaper. Watch what he does with his cell phone.
We'll just pop this iPhone into it like that.
He shows how simply his modified iPhone produces a cardiogram for a patient.
So you just put your fingers on it, and there you go. And in the second, in the first second, then it stabilizes. There it is.
The device was approved by the FDA in December and is now sold to physicians for $199. Topol tells his patient he just saved a $100 technician's fee.
So are we close to using this to say I'm going to diagnose you and prescribe 4 or 5 apps instead of 4 or 5 medications?
Well, these days I'm actually prescribing a lot more apps than I am medications. You can take the phone and make it a lab on a chip. You can do blood tests, saliva tests, urine tests, all kinds of things, sweat tests through your phone. This is a powerful device. And I'll just hold that on there again.
Topol's patient, Ron Thompson, is dealing with several significant heart issues.
You saw that on a phone. Were you just amazed the first time you saw that?
Absolutely. I used to have an ECG machine hooked up to me and put all these, shaving my chest and stick them on there and put the electrodes or whatever. But yeah, no, this is incredible.
Topol also uses a portable ultrasound, a V-scan, to image Ron's heart.
So,
The V-scan is made by GE, a parent company of NBC.
Can you see that? See how strong that is coming together?
He does in the office what would normally be a separate test costing $800.
There's 20 million, over 20 million echocardiograms done a year. So 20 million times $800, that's a lot of money. Probably 70–80% we can get rid of just by having this part of the physical exam.
I was surprised when you saw Ron that the technology did not get in the way of the doctor-patient relationship.
Actually, I think it helps make the whole interaction much more intimate. Because now I'm sharing the results in real time. There's so much technology now that we can, by using the digital structure that exists today, that we can make the office visit an enjoyable thing. And not only that, Nancy, but it doesn't have to be in person. There's no reason why a lot of office visits in our office could be done remotely.
Ron could take his EKG home, send,
yes.
And we would be
we would look at it together. Or if I got him a wireless ultrasound, and he just puts it right there, and I just say, okay, take a deep breath, I could be watching it in real time. I mean, anything that we do can be done remotely.
When Topol came to Scripps in San Diego from Cleveland, he started a new chapter in his life.
When you moved here in 2006, you just left the
So the punchline there is he got run off from the Cleveland Clinic. So not everybody likes change, but yeah, it's very powerful technology, and I just wanted to show you that summary so that you guys had a good sense of it from a leader in the field. Yes, sir.
Do you think one day we'll wind up with sceneries like we're on Star Trek?
I do, and I think that'll be okay. You know, I think it'll be a good thing. One thing that's interesting to me is these brain-machine interfaces, for devices that for people who can't walk and have mobility issues and other things, where they plug the electrodes into the brain, or they don't even have to plug them in anymore. You can just wear a little helmet. And now I've even seen them where it doesn't even look like a helmet. It looks like the underside of the helmet. You know, like a hard hat, and it's got the little stripe, and you know, it's like one stripe down the middle and then a little bit of a ring. They've got them that small now, where it's just a little ring and a little stripe down the middle, and they're doing basically an EEG, it's electroencephalogram. You know, they're measuring brain waves, and they're able to have your brain communicate with the machine that is holding onto your arm and help supplement you move. And I mean, there's military applications on one end of it, right, to help troops move better and do, you know, pick up heavier things. But then on the other end of it, there's the whole part that helps it reduce suffering and increase mobility and normalcy in the lives of those who are disabled for whatever reason. So it's very powerful, sir.
Technology will not totally eliminate alopecia, will it?
I don't think so. We're humans. We're social beings. I think what it does is it eliminates the unnecessary medication refill visit, right? The only way you can get the medication refill is if you go see the doctor, so they can get the claim, and they get their $100, and you get, you know. But now it's cost you half your afternoon, or half your morning, or your whole day, because you got to do 2 or 3 docs, and they're all at the same place. And I mean, it just gets to be a nightmare, right? And so we can eliminate a lot of those very low-level appointments and see more people, and still, you know, doctors can still do fine financially. So it's kind of a win-win.
They said so much money. I bet you the premiums are still going.
Well, you're on to something there, but yes, sir, in the back.
I got 2 questions. As the Affordable Care Act,
HIPAA.
so Epic.
Oh, Epic. Yes. 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 That's the one I spent the most time documenting those encounters I was telling you about, which was started by a bunch of nurses in Wisconsin, which I thought is interesting because it's doctors who were using it who were wasting all that time. But yes, absolutely, we can replace Epic. Your first question, I apologize, I got so caught up in Epic. Is that actually, it's interesting, the meaningful use thing, the thing that we talked about, the mandate to adopt electronic medical records, that came in the 3rd bailout bill, the Affordable American Recovery and Relief Act, whichever one I was, I mean, the 3rd bailout bill, just before Obama took office. So it was actually part of a different bill, but of course, the Affordable Care Act helps. Why? Because, at least in our view, it adds the demand to the system that the supply wasn't able to handle before, and now particularly is it going to be able to handle. So it really stresses the system to have to be better, or else it won't survive. And so one of the things our software does is to help doctors do a lot of the coding and the back end stuff. I didn't talk about here because none of us care about that unless you actually, it depends on like how well you do it is how well you get paid. Then we would all care much more about it, right? But for docs, they have to, and so it's become a game. It's become a game whereby if you don't put exactly the right physical exam finding, or exactly the right review of systems, or exactly the right phone number, in the format that they want it, they're going to reject your claim, and now you have to have a person go back and look at the claim and fix the phone number, and then resend it all, and they do this hundreds of times a month. And now we're talking about major money because this is salaries of full-time employees, which, as we all know, is the most expensive thing in most businesses. So it truly becomes a costly proposition. One of the solutions to that, however, to avoid the implications of the Affordable Care Act, is what's called a direct pay model. Either concierge medicine, which is where the doc is sort of always on call. You pay a subscription, maybe $500 a year and $50 a month, and now you kind of have your own physician. The problem is it takes the doc from a census. Let's say you talk about in medicine, a census, a patient population of about 1,200 per doc, down to like 200 to 300 per doc. Well, the 200 to 300 are getting excellent care because they sort of have their own on-call doc 24/7. But what about the other 900 that now aren't getting any care from that physician, right? So it can really, it's dangerous in a lot of ways because it can break the system. And this guy's book, as it turns out, the name of his book is called Creative Destruction of Medicine. So it's interesting in that sense that we're I mean patients, providers, and all of us are being put in a position to have to come up with creative new models that actually risk breaking the current model, which probably needs to be broken, but if we break it rather than sort of change it over time, then it creates a lot more problems than it solves in the short term, but maybe eventually we get to the same place. So I know that's a murky answer, but in some ways it's good, and in some ways it can be bad for all of us, I guess was my, yes sir.
Traditionally, error rates among physicians and hospitals, where you've got this huge number, over 100,000 a year of medicine health. Somewhere amounts to 3,747 crashing every day.
Sir.
If that happened to the 747, we would know what's going on. But this will help, I would assume, stop some of the errors, because if the doctor's prescribing some med, and you're also getting another med, the machine will tell you it's contraindicated.
A lot of those things it will help with. The contraindications, the drug interactions, drug allergy interactions, all of these things that will help with tremendously. I like the more advanced applications of it, like wrong site surgery. They cut off the wrong leg. The ability of it. There's a book by a guy named Atul Gawande called The Checklist Manifesto that I thought was very interesting and really helped to inspire a lot of our approach, which is basically the checklist. The reason that speaking of airlines, the reason our airlines are so safe is because they run checklists and they repeat things back to each other, and they, what's it called? Crew resource management, CRM. One of the guys up at my medical school is a pilot and a physician who actually helped to invent that whole process, and so we got a great education on that and the value of it. And then, of course, a couple of years later, Atul Gawande came out with his book, and so it's very interesting. Some of the things that are extremely simple that can really go a long way, and I think checklists and all that. So the bottom line is, it's systems like this that are going to back end those, that are going to make it easy to do the checklist, and then if the checklist is done, and the system can still monitor it. So, like for instance, if you've got a sponge that instead of having to do the post-op X-ray, after operation, you have your belly operated on, they have the little sponges. They call them sponges. They're kind of like rags, and they call them sponges. And they have what's called a radio-opaque strip in them, right? So when you take the X-ray, it's easy to see the strip. Radio-opaque means radios can't pass through it. So it shows up as bright white on the thing. Well, then you know. But instead of exposing everyone to that radiation after they have their abdominal surgery, instead of wasting that $80 or $120 or however much your insurance company is paying the hospital to do all this, instead of doing all those things that have risk and cost and whatever, why don't you have an RFID tag that says, look, 10 sponges went in the room, and 9 went out of the room. Then you take the X-ray, right? So it helps to save the routine nature of the X-ray and says only when you think you're going to need it do you, and that's in addition to all the current things where you count back. And they have a lot of these processes now. So hopefully we can rest assured that some of this stuff is being listened to where the nurses will actually physically count back to each other. 1 sponge, 1 sponge, 2 sponge, 2, 3, 3, 4, 4, and then time up. Anyways, the whole process. So what we're trying to do here with the technology is complement those what you call best practices. So yes, sir, I think there's a tremendous amount of potential for that.
Do you think this will lead to more preventative medicine, or just treating people when they get sick?
Well, that's the idea of the predictive modeling, is to monitor them to the degree you want to give this information. Your insurance company might incentivize you to it. You might get a copay free or something. There might be some incentives around that. But the whole idea is that we're collecting this data, and when we see your sugar spike or your blood pressure drop or your blood pressure go up, we can reach out to you, or your cardio, your congestive heart failure getting worse. Then we can reach out to you and prevent you from that $8,000 to $10,000 hospital admission. I don't know. I think it'll be interesting. But they might sell less drugs, and the insurance companies might not be able to charge as much for their insurance plans. I think all of which is a good thing for everybody. Because what happens is, even though the insurance companies get less money, they get to keep more of it, right? So that actually aligns with their incentives, right? Because they want money, but they're happy to get a broader margin if the overall cost is less. So what we're trying to do really right now, and this is kind of interesting if you haven't thought about it much. Right now, doctors, patients, and insurance companies are all at odds, right? The customer of the doctor is the patient, but the patient is not actually the customer, right? Because the patient is not paying the doctor. I mean, maybe 25 bucks here and there, whatever, but just stay with me. The patient is not paying the doctor as the customer. The insurance company. So doctors are in a position where they're providing a service to someone who is not their customer. And the incentives are never going to be aligned in that way. The customer is paying for a service for which they, as the insurance company, did not receive. This other third party over here received that service or that product. And so if you start thinking about it from the incentive perspective, it's set up to be difficult. It's saying, well, the doctors are going to make it, or rather the insurance companies are going to make it hard for the docs to get paid as possible because they get to keep more money, they get to get more interest, So anyways, it's a big mess, and what we're trying to do is trying to align those incentives a little better. To say, look, what's good for the doctor is good for the insurance company, is good for the patient. And right now, it's not that way. That's what we're trying to do. Yes, sir.
When I was a nuclear missile launch officer in the Strategic Air Command, it was called demand response. What was coded for the crew commander, the deputy commander read, and vice versa. So there was check, counter check, check, counter check. And it was listed at a recent dialogue you just gave about attorneys like AJ back here. Yeah, that's part of the equation too, sooner or later.
Yes, sir. No, there's no doubt. But let me tell you a little bit, but let me tell you what's even more concerning, and we're kind of getting off topic now, but it's a very interesting conversation, is end-of-life care. I mean, my data is a little bit, I'm pulling back from when I did the fellowship, but something like 40% of all healthcare dollars are spent in the last 90 days of life. Think about that. Spend about $2.5, $3 trillion a year on healthcare. 40%, almost half, are spent in the last 90 days of life. So if you want to bend the cost curve, we heard about that with the whole Affordable Care Act. If you want to bend the cost curve, stop talking about death panels and politicizing all this crud, and let's get serious about end-of-life care, because we're spending a lot of money. I mean, I've had people under my hands, ribs breaking, as I'm doing CPR on them because they want to exhaust all possible measures. Do you think it's enjoyable to go into the next life with your ribs breaking and blood coming out of your mouth and all of these horrible things that can happen? No, sir, you don't euthanize them. You just don't go to extraordinary measures and break their ribs and injure them in the process or in the name of saving their lives. So you don't do anything proactively. You just, every case is individual. There's no doubt. Every case is individual. When it's my mom or my dad, that's a much harder decision to make, and we all get that. But we need to come together as a community, either locally, regionally, nationally, maybe in the world, and talk about these things and deal with it, because it's just costing too much money, and we can't afford to spend $20,000 a day taking care of people when they're only going to live for 15 more days. If we do everything we can, they're going to maybe, and then you got to think about quality of life. What kind of quality of life does someone have with the respirators and the electrodes and all this stuff on all the time? I mean, look, I've seen a lot of people suffering in hospitals and stuff, and I just don't know. I don't have an answer. I'm not here to tell you what the answer is, but I'm telling you it's a question that we got to start a conversation about. Yes, sir, in the back.
Do you foresee a time when researchers will be able to sort of reach into the data that the clinics gathered to find cases for anonymized data.
Could be anonymized data. It could be opt-in research. So let's say you have an illness. You want to know what type of research is going on. You opt in to the available pool of research, and then they have access to what data you've made available to them to scan if you're eligible for a research study. I mean, there's all kind of things you can do with structured data, and that's one of them. I mean, there's no question. We absolutely want to do that. Yes, sir. Yes, sir.
You said that we log in and check out like that. I like the fact that we've been listening to what the doctor says and stuff. I don't know in the past, I generally call that I'm calling numbers. They say we call it, somebody we call, and we report it. First I was on the phone, I said, I hope you don't mind, but I'm reporting your conversation. And their answer is generally, no, I don't like to be reported. Now, I'm wondering if that scenario, how is that going to be like doctors if you call in, are we going to be able to be on the same platform as price files? And we can, is that going to be a problem?
No, and that goes back to the patient-initiated recording. So the doctor's not recording anything. There's a system happening in the background that will stream it, convert it, and then destroy it. But it only keeps, so if you talk about the football game, and you talk about hunting and fishing, and you talk about the wife and kid, you talk about whatever you talk about, none of that stuff is kept because it's not related to medical stuff. And so, but it's only on the patient side, which you have the liberty to do now. I mean, Louisiana's a one-party consent state, so legally you have no issues. And your doctor's office, many people will bring in, I mean, I can just tell you from personal experience and from what I know of other, that, many people will bring in a little micro cassette. If they're dealing with a cancer episode or a heart attack or something, they do a post-op care or something, they'll want to know exactly what the doctor said so they can go back and re-listen to it and re-listen to it. And so I figured, well, since they're doing that, why make them bring in two devices? They just do it through their phone and then have that as part of their medical record attached to that appointment. And so then they can know what the doctor said. But the patient does that, not the doctor.
And is your software implemented in all hospitals?
Not yet. We're only on our beta site. We have a pilot that's getting up and running now, and a beta site that will be up and running by the end of the year.
Because the reason I asked that is because the exact same thing we showed in the video is back to puts it on these quantity chefs and hospital platforms. Everybody's all in the same system. But it would be nice if you could log into our database and see what's going on.
I agree, and that's why we started with the person, not the patient, but the person as the fundamental unit of our system. And so you as a person, it's your data. The laws say it's your data. So the way they used to get around this, I don't know, for those who are not in healthcare, it's kind of interesting. You own the word, you as the patient, own the words on the page. The doctor owns the paper. How you figure that? I know. But now, and so I took that and I said, look, if that's how it is, that doesn't make any sense. The patient needs to own their own information, and if they need to correct things, if they need to remove things, that's their prerogative. But the patient really, it's a patient-centered thing, like I said earlier. Yes, sir. Oh, is that first? I'm sorry. Yes, sir.
I worked all of my life, paid insurance, all of my life since I was a teenager. Okay? Why should somebody who never worked a day in their life, never paid a nickel to anything, the whole group of me had the same access and had the same health care and everything else as I did? It'd be moved in front of me in some cases.
So let me answer that. So this pulls on my policy. It is a bad subject and it's a tough subject, and you have a right to be frustrated about it. But the question is, what are the alternatives? Let me give you a few statistics. PricewaterhouseCoopers did a study a few years ago that said people get about 70% of the health care they need. Period. So right, we have the it's not Stark. I forget the name of the law about the emergency rooms. Right, you can't be turned away from an emergency room. Right. We decided as a culture, look, if somebody's in an emergency, because we would want that for ourselves if we were on downtimes, then we're going to give that and make sure everybody gets taken care of. So what happens is they get about 70% of the care they need. What that means, though, is that they come in sicker, they cost more money, and they still don't have the money to pay their bills. And so guess who gets to pay their bills? You do in your insurance. Well, what are we going to do? We're going to throw them away on the side of the street and let them die, like have a little hut next to the hospitals that people who can't afford health care go to die? I mean, That's not how we are. That's not who we are. It's not who we want to be, I think. And so, we have to deal with that. And I think that's what the Affordable Care Act is, and some of those efforts have tried to do. And it's very imperfect. I'm not here to defend it. But what I am here to do is say that it's trying to write that balance somewhat and say, look, if you're gonna get health care, you got to put something into the system. You can't be a free rider, which is kind of the term they use. You can't be a free rider.
That's what's happening.
That's what's happening now, and even though for all the grief that it's gotten, the Affordable Care Act is trying to move that. It's trying to get the invincibles, right? The 20, basically 18 to 35-year-olds who don't have health care and can cost a lot of money, right? The number one or number two cause of death is accidents, right? Car accidents, boating, all these accidents for the kids. They don't have insurance. Again, guess who pays for that? We all do, one way or another, through our health insurance, through our tax dollars. We all go. And so, if we're sick of paying for it, are we going to go prevent the kid from going on the boat or prevent the kid from drinking and driving? We can try. We got all the education tools, but we can't do it all. And so we have to do something. Well, get the kid to pay some money in, even if it's just a little bit. There's a bunch of them, and so the little bit goes. So anyways, all that. So I'm with you, but I think it's the technology coupled with the systems.
And more pouring in all the time.
No, it does. It gets you going. I appreciate that. Yes, sir.
I can go to the gym and have an app with technology. They know that I have high cholesterol, so I see fitness trainers using their technology and say, okay, you need a 3-mile run to lower your cholesterol. I think doctors have it already. Doesn't matter, but I think we're trying to get that benefit so we don't have a lot of healthcare costs. Because I think part of the issue is that nobody's holding I do agree with that. If I have to pay for your health care, then you need to invest in yourself. Keep my costs down. I think also that as it contributes to this health care system, that should be so explore to say, you gotta, I go into your doctor, I go into, I want to learn how to do this gut. And you see the old cut now, and you're like,
Yeah.
I come on your app, and there's a whole list of stuff right there. Just waiting on you.
And what if your insurance was 20% cheaper? At the end of the year, you got $1,000 back to help with Christmas because you did that. And so, so how does it? And so, one of the things that sort of we set out to do, again, we're at the person level, right? That's the fundamental universal, not the patient and not the surgical, it's not the hospital patient in long-term care. It's the person. And so, what we set out to do was, and the way we like to say it is to give this data a home at the doctor's office. So right now, if you use the Fitbit or the Nike Fuel Band or the little shoe insert or whatever type of little monitoring or walking fitness device you're using, now you got to print it out. If you're using a glucometer, blood pressure cuff, it's all the same. You either got to print it out or you got to write it out. Neither of which the doctor is used to seeing. It's not graphed for the doctor nicely against your medications and against your lab results and all these things. And so what we've set out to do is tie in all these devices to our system and then give that data home at the doctor's office. Present it to them when you walk in the door in a way that they understand, in a way that makes sense to them, in a way that they can use to improve your care. Let's do one or two more. Yes, ma'am.
I do have yearly and examination. But the problem was when you notice that your device if you're in the same system, but in the option system, if I go to my oncologist, she doesn't see what's in that option doesn't see her. And even when I had to get, when she had to get records, they sent me a bill back to pay for.
Isn't that great? They charge you for the paper? Oh, That's exactly right. So that's what, I don't know, did it not come up? I'm sorry. Okay, so that's what, so I showed that big long list of things, and it was called the Health Information Exchange. That's what part of our system does, which is connect to these other systems and then exchange that information. And earlier, you remember when I talked about the family history stuff and how we used to could not do that, but now we can? It's because they've standardized it. They said, all right, guys, we're going to all talk to each other, but we're going to all use English rather than Chinese or German. And we're going to talk, and that way we can communicate. And so there's Louisiana Health Information Exchange, which has like 100 or so organizations. They have about 50 of them live. The problem is they only exchange certain bits of information, right? So one may do lab results, the other may do demographic data, the other one may do radiology and imaging. So there's different. And so what we're working towards is the ability to exchange that data, and the older systems are limited by the degree to which they are unstructured. And what that means is the degree to which they can have the misspellings, the headache example and all that. Well, how do they know that HAD, all those examples that I gave, in your system in Ochsner is the same thing as the headache in your gynecologist thing because of hormones or because of what, so there's all these different things, and if the systems can't talk to each other, then it doesn't do anybody any good. So that's one of the reasons that our data is structured. It's not just for analytics. It's also that we can communicate with your system and a different system as well. And so we're trying to do that now in Southwest Louisiana. We're trying to tie together 6 different systems without using it. So we'll do one more in the back. Yes, sir. Not yet, we just don't have enough data yet. But what'll be interesting is things like knowing, when you do susceptibility testing in a lab, right? When the doctor goes up to prescribe your medication for your child's earache, it knows which sensitivities, the doctor knows which sensitivities are most common in your area, so that they prescribe you the medication that is not only safest for your child, but also is most likely to kill the bugs that are most common in your area. So there's a lot of things that can be done with this information. Again, it's passively collected, right? The lab results are going to get done, they're going to be sent, they're going to be exchanged, but now we're taking that to the next level and helping to put that to good use, to make sure that we don't create more antibiotic resistance because we're giving everybody medications that may or may not kill the bug that causes the ear infection. So yes, sir, we're doing a lot of those things, and I'll go ahead and pause there. But thank you guys so much. It was a real treat.
Peter, thank you so much. We had more questions tonight and more interest tonight than I think in any other program we've had.
I think you're right, AJ.
I'm happy to come back to talk about anything. I love all this stuff, and
I want to thank AJ for arranging for Dr. Ragusa to come, and thank you for driving all the way from Lake Charles. That's fantastic. Just wanted to remind you